offering free and widely available high quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available, but please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3, 2,
1.
Well, good morning, everybody. My name is Jens Chapman, and I'm speaking to you from the beautiful Seattle Science Foundation facilities. Today is Wednesday, February 19, 2025, and welcome to STED Talks, Spine Technology, Education, and as the frequent followers from around the world know, the D is multidimensional. It is discovery, it's discussion, it's debate and discourse, if we take a more critical slant. And today is a topic at hand that is rich in discourse and discovery. It's a great privilege to have with us in person. I'm going to introduce him in great detail later, Dr. Ryaby. He's a PhD, and he's here with a company. So as you know, the main talks and our STED Talks are non-CME accredited. So we have some corporate speakers here, and this is Dr. Ryaby's role here today, but he's one of the foremost leaders of bone healing and understanding of bone healing in the world. And a small pitch for him, I'm not going to mention the company yet because this is the CME part of our presentation, has had an instrumental hand in pulsed magnetic. No CME today, I can speak. So he has had pulsed electromagnetic stimulation and his role in bone healing as one of his key discoveries. So this is a relatively big topic. And so he knows bone healing, he knows what our bone does. And this capacity are for wonderful fellows who are here today. I'm going to show him some cases. I'm not going to ask for clinical judgment necessarily unless he wants to venture to that realm, but we're going to ask him some questions regarding bone physiology because, again, he has a more in-depth understanding than any of us combined probably. I don't want to insult you in the world, but myself certainly. So in that vein, I'll ask maybe Dr. Nick Minasali to come up first. He is originally from Philadelphia, and he's still wearing the green color of the Eagles with pride, and he's going to show a case about a case that we did not too long ago, and we'll ask Dr. Ryaby some questions. So Nick.
Perfect, thank you. Good morning. So first case here, no relevant disclosures. This case was a mid-40s-year-old male with chronic severe activity-related low back pain with some component of left greater than right radicular pain. Does have a past medical history of Crohn's, but this is well controlled. Non-smoker, social alcohol use. He is a single father of 2 young children, and his BMI is in a very good range at 23. He's trialed conservative management with medications, physical therapy, which had to be halted due to worsening low back pain. He's also undergone 2 different types of blocks, bilateral L4 medial branch blocks and bilateral L5 primary dorsal rami blocks. With one of our physicians here at Swedish. And the patient noted some mild relief with these, but again, the pain is persistent. On exam, he has some mild hip flexion weakness, but it's more related to the back pain itself, and then bilateral EHL mild weakness. So here we have our AP and lateral films, flexion extension radiographs of the lumbar spine with degenerative disc disease and collapse at L5S1 without any significant spondylolisthesis or instability. Here we have an MRI demonstrating that same L5S1 degenerative disc disease collapse. On the axial, you can see some mild facet edema, but no significant hypertrophy, really no major central stenosis. There's a small disc protrusion, and then foraminal stenosis was mild bilaterally. And then L4, there's also some mild degeneration, but not as significant, and another central disc bulge, but no major foraminal or central stenosis there either.
So let me interrupt you here. So, oh yeah, show this also. This is great.
So in working this patient up and discussing treatment options, we also pursued a SPECT CT, which was really did not show any significant facet arthropathy uptake posteriorly. There is some mild uptake in the L5-S1 disc space, as you can see, but this kind of ruled out any significant posterior involvement or degeneration.
As you go through, yeah. Can you run that video? Thanks. So an orange or yellow signal would be a sign of high osteoblast activity. And certainly the facet joints are calm and there's not much happening in the disc space, right?
Right.
So if you go, oh yeah, what's the next slide? Then we'll go, perfect. So I know you're a bone specialist. Disc degeneration is obviously something that is intimately involved with bone health. I usually harbored, and this is the question and formulation, so allow me that extrapolation, 3 components of disc degeneration to be causative. One is genetics, one is malnutrition, that includes nicotine use, unregulated diabetes, microangiopathies, stuff like that. And the third component is trauma, whether it's occupational trauma, sitting as a new smoking, for instance, or some hits. In this patient, we have mainly a single level disc degeneration. So knowing what you know in terms of physiology of cells, what do you think is going on when a patient has a single level, pretty symptomatic disc degeneration like this?
So,
Can you use a
I always
microphone?
worry about.
Can you use a microphone?
Oh, sorry.
Thank you, sir.
I always think about the end plate injury and really say violation of the integrity of the end plate. And I think that's the real driver for the degeneration, because obviously the nutrition is coming from the end plate, from that vascular space. And so to me, surely lifestyle factors, all that's negative. If this person happened to be a manual laborer, putting a lot of load on it compared to the average person. And then, of course, genetics. But if it's genetics, I would expect to see more levels that look more like L4-5, going all the way up to L1-2 or something like that. And the fact that it's really isolated, L4-5 doesn't look good, but might last 10 more years before it becomes really symptomatic.
And you're old enough, like me, to remember a time in the early 2000s, I believe. There was a host of Danish studies that identified infection of nosocomial agents in the disc space. Is that a factor here? Did that ever pawn out over time? It was kind of discredited, sampling errors.
Yeah, I don't think that was real. And I always wanted to know, where did the infection come from? Because if it was 2 years post-fusion surgery, then that would be plausible. But this was really like an iatrogenic infection of no known origin. And why would it only show up in the disc space?
So as a young man, he's a tech worker and he is a past boxer, a man of my heart. And he had some radicular symptoms, but no real radiculopathy, right? One more question and then we'll go on to the treatment, because that's obviously something of some controversy. Whether we fuse a patient with this or not is the big question, assuming he's fulfilled all, and I mean all, sustained non-surgical care. So this end plate sclerosis, can you go back to your CT scan again? Is this a manifestation of a degenerative disc, or is this why the disc degenerated? What's happening ultrastructurally with the sclerosis? There was a CT, a plain CT, I thought that you showed.
I just showed this. I have an
Oh, you did
MRI.
not put the CT in. Can you show the plain film again? So this sclerosis, is this what caused the disc to degenerate or not? Yeah, so we see this end plate
Yep.
sclerosis, condensation of sclerosis. Tell us what happens ultrastructurally and what signaling leads to this.
It's a good question. So from my standpoint, the end plates get injured. And then that sclerotic bone is the body's attempt to lay down a structurally replaced end plate, which never happens. It becomes sclerotic bone. And I think you just said that he's a boxer or a
He was an
former
ex-boxer,
boxer.
yeah.
So to me, that's another, so even though he's a tech worker, he probably for a couple of years, if he was really a boxer, he probably really loaded his spine a lot, maybe even got knocked down many times. And so it's not the scarring. Sclerotic to me is like scarring of the bone. There could be ligament injuries that give too much motion there. And that's another reason why you'd get scarring if you're trying to repair the end plate.
Is this the body that wants to heal, or is this a stress dissemination tactic of the body? Is this again, just walling off effort?
No, I think the initial biology is to try to heal the end plates. And then it's these other factors like maybe too much motion, and that leads to scarring. And, I look at this and I'm sure there's ligamentous laxity there.
Vertical.
Hard to know. I mean, these are, we'd love to have like biopsies of these so that you could really
We
study
did a biopsy,
that.
all right, but not in the way. So this is a very good answer. And again, he had single level disc disease. These are modic changes. He does not have a hot bone scan. The facet joints are good. This is a very active guy. The boxing thing, I'm going to tell you, so in my time at UW, I had a plethora of athletes. The only athletic profession that was tied to bad L5S1 discs were rowers who spent too much time on the ergometer. Tell us what we did to move forward.
Yeah, so again, keeping everything in mind, we went ahead with a anterior approach and performed an L5S1 disc replacement. So here on the top left, you can see the distractors kind of getting back some of that height, the trial on the bottom left, and then the final implant in the center and right side. So this is a great case, and the patient did very well. He had the usual discomfort in the abdomen, but overall his back pain was very much relieved pretty significantly even during his hospital stay. And he noted his leg pain was also improved. So this was a great case.
So questions to you now. So this is a debatable thing in a young active person, especially somebody who has early disc degeneration at L4 or 5. I'm very reluctant to perform a fusion. A fusion is considered the quote gold standard. With now 25 years in the rearview mirror, thanks to the groundbreaking work from a Texas Back Institute colleagues, Scott Blumenthal, Rick Geyer, and Jack Ziegler, changed our literature dramatically and provided phenomenal basic science as well as clinical data. I personally think a disc replacement should be considered the new norm to try to decrease adjacent segment disease, especially in the lumbar spine, less clear in the C-spine. Here's my question to you. We get inundated with manufacturers claiming bone ingrowth and these end plates. Can you tell us, without going into any manufacturing details, what the chances of bone are to actually heal into some metallic structure that tries to fake out osteoblasts? Is that realistic or not? Are there any chemicals in there that can improve that bony ingrowth?
So I'm a believer of bony ingrowth, but you have to remember what are the factors that would allow for some limited bone ingrowth. And it is limited because you're not going to have 3 millimeters of 400 micron 3D printed pores on each end plate, because to manufacture that, it would be just a very costly thing. So all of the porous coatings are really smaller porous coating. Everybody's gone to nano now, that's the hot word. Like having a nano feature is gonna get an osteoblast to lay down more bone per hour or whatever. Not realistic. But I do believe, and it's based on some work we did with Colorado State, that if you have a 3D printed end plate, which I don't think this is, but if you did, and you had porosity in the range of 400 to 500 microns, you do actually get bone growing into those pores. The pores obviously have to be interconnected, and that does happen. You only get, we're talking about maybe 100 microns worth of bone ingrowth, but enough, I think, to add some biomechanical stability. Here, this is probably like a sprayed surface.
Yes.
And probably you might get good appositional growth without any sort of weak areas or with more strong apposition than poor appositional growth. But you do see these discs every once in a while migrate out over time.
It's very rare, but yeah, it can happen. So one other question right here is, we get inundated with statements by some manufacturers more recently that not just claim 3D printed, which is the magic word, and nano, you hit the two hot button words on the head there, but they also say that they can electrically charge the surface of the metallic implants. Is that real or not? And are there some chemical compositions, some alloys that are more conducive to bone ingrowth or less?
Well, as you know, Dr. Chapman, you can't make major changes to the metals because from an FDA standpoint, that would be a no-no. So yes, you can charge a surface, but once you put it in the body, how long does that slight surface charge modification really stay there, and does it really aid? Probably aids in cell attachment, at least when you first put the implant in, but is that charge doing something good for you a week later? I don't think so.
Great.
I mean, there are people who are doing piezoelectric things, speaking about what I'm going to talk about later, where they're putting films on these end plates or on cages that generate, when you're loading, ambulating, you're generating small little electric currents. But again, to really prove that in an FDA setting and get a claim that your now piezoelectric cage is actually getting you a better fusion or a faster fusion, that's a 5-year clinical study, hard to prove. Companies might not want to try to prove that.
Okay, next case, I'll ask Dr. Colin Gold, you're originally from the University of Iowa and you're a surgical colleague. Thank you, Nick, great job, to come up. And he has 2 cases, so we're going to go a little bit faster, but the second one is particularly, I think, fascinating. And keep that end plate physiology and bone healing in mind. So Dr. Gold, curious which case you'll show first.
Thank you. So first case is a mid-70s-year-old woman with progressive pain between the shoulder blades. It's been ongoing for months. She's ambulatory with the assistance of a tall walker. And maybe the thing that kicked this off was a fall about 11 months prior to our intervention that resulted in transient inability to walk at all, that then recovered. She has a past medical history of breast cancer and had a bilateral mastectomy, no longer on any kind of treatment for this. And social history, she lives in an assisted living facility with family members not there but nearby. On physical exam, she has some weakness in both arms, like distal arms, and proximal left shoulder due to an injury, but otherwise neurologically intact. And imaging, this is the key finding here. We have this T4 level burst fracture with retropulsion with the cord draped over it. And then you can see this pre-op standing films over here. On a separate scan, I measured her Hounsfield units at L1, which was 71.5. Her most recent DEXA was 2019, which was like 5 years ago. T-score at the femoral neck was negative 2.0. At the time of her workup, she was only on calcium.
Which is a mistake, yeah. So I know you're not a bone health specialist per se. What can you tell us in terms of bone health optimization beyond hormones or newer anabolic agents or taking vitamin D and getting some sunshine? So specifically talk to us about ultrasound loading bone, because bone actually signals itself, and whether or not electrical signaling can enhance bone health.
So, you know, when I look at something like this, I think about Forteo or Evenity treatment, because clearly no one should be walking around with a femoral neck T-score of minus 2.0. So just having said that, are there other things that can happen? I'm saving a comment for my talk, but we unfortunately have never studied the effect of electromagnetic fields on bone density in an osteoporotic patient population. It has been done in a couple of labs. Joe Spadaro in Syracuse did it in distal radius osteopenia, but he didn't see an effect with pulsed electromagnetic fields. And I think he was using a competitor's, or I know he was using a competitor's electromagnetic field, but still the same FDA-approved indication for non-union treatment, et cetera. There have been some European studies looking at, and Japanese studies looking at both ultrasound and different types of electric fields, but it doesn't really seem to be enough. You know, you can argue there's like a tiny 8% increase in density. Well, it's not like Forteo or even the old bisphosphonates. Over the course of a year, you can get really big bone density changes. You know, move yourself from osteopenic to normal or osteoporotic to mildly osteopenic.
But to get our bones to be healthy, they don't just need a good nutritional basis, they need some hormonal balance. They also need loading, and the loading is an electrical signal, right? Calcium channel.
Totally.
Messaging is the key. Can you influence that then at all with electromagnetic pulsed signaling or
I don't know whether
loading?
Clint Rubin ever spoke here, but remember Clint worked for 10 years on the vibrating floor plate at 30 hertz, hoping that much higher frequency compared to ambulation or running, and he had shown in animal models that in fact it was very stimulatory in terms of growing back bone in different osteoporotic models, but it never seemed to work in the human clinical trials that are done. Now, is that because once you're postmenopausal, your mechanostat, and remember Harold Frost used to talk about this, that your mechanostat changes, and I think that's true, because certainly there have been big studies looking at weightlifting in elderly individuals and not really seeing changes in bone density or bone strength with really serious weight training programs. So I don't know, I go to the bone and mineral meeting, which is the osteoporosis meeting, pretty much every year. And it is a little frustrating. And I'll just tell you that in a clinical study I'm going to show you on lumbar fusion, when I was at the company, we wrote into the protocol to do DEXA scans at T0 when they got the bone stim device. And then whenever they stopped using the bone stim device, which was at least 6 months of bone stim use out to a year. And unfortunately, COVID happened, new management came in, no one wanted to spend it, and DEXA scans are not expensive. You know, you're talking about $250 maybe. I don't know what they are here in Seattle, but I'm guessing that
It's not
they're
well reimbursed either. So Colin, at the University of Iowa, you come from one of our major universities in this country that also has a very successful merger of basic sciences and clinical sciences. Did you have an integrated program for bone health? And what about anabolic agents in a patient who had cancer before? She had breast cancer.
We had a orthopedics department. So the Iowa Ortho department had a bone health clinic, and neurosurgery could send patients to there, but we didn't have anything as our own department. For things like anabolic agents, it was often that we had to send them to endocrinology, and then it was kind of at the discretion of the endocrinologist to.
Yeah, to the present
they
date,
will.
our society, our healthcare system has hurdles around every corner for bone health. Yet this is a pervasive problem that happens on a nightly basis. Upper thoracic burst fractures are one of our nightmares. They're not braceable, really. And in this case, it led to thoracic myelopathy. So let's carry on.
So this was the surgery we did, T2 to T6 laminectomy, T4 corpectomy. We also did costotransversectomy at the 3 levels surrounding that vertebra to loosen it up. And then C2 to T10 posterior fusion with cement augmentation of T10 and LIV -1, so T11. So here's some post-operative CTs, just to show the cervical spine. Pedicle screws at C2 with lateral mass below. And then the thoracic spine, we did bilateral expandable lumbar T-lift cages because the space was so small, but completely disconnected the vertebra at that segment, so we're able to get a good correction. Notice, I'll point particular attention to T10, where the cement is, that there's no fracture at this point. And then the patient next went to the floor, or ICU, extubated in the OR for MAP goals and completing stress dose methylprednisolone, put the wrong word there, methylprednisolone course. On the floor, we ordered a TLSO brace after getting the standing x-ray where we noted T10 compression fracture starting to form and kind of focal kyphosis in that area. Patient did well overall and was discharged to a SNF on post-op D8. Has yet to follow up to see how this fracture is progressing.
So I just wanted to share this frustration with us. We had put her on anti-resorptive medication. Anabolics are not given by our endocrine group, just like what I gathered from Dr. Gold, due to oncologic concerns. I'm still not sure how solid that fear actually is, but I have to respect their expertise. The point here is, can electromagnetics actually accelerate bone healing or not? Can we get a boost effect of bone healing?
Well, in a long construct, that is going to be one of the things that we're going to be working on. So I don't want to use the term, so adult deformity patients, there are a few doctors around the country, very well-known thought leader doctors that use the spinal stem device on their long constructs. One of the trickier things is getting it paid for, but they figured out how to get it paid for with certain insurers. I'm only learning about this. I've only been back at the company 4 weeks.
Got it.
So I haven't quite gotten my hands around like everything that's happened the last 5 years.
If one of our Gold Pass members would like to advise me on the lower level that they would have chosen, we obviously debated stopping at T1011 versus L1. I know our UCSF colleagues actually go to the pelvis in these patients. That would have probably overwhelmed her physiologically. Dr. Shamandal, Dr. Fayaz, Dr. Randy Davis, Senegora Benz, Dr. Carnes, please let me know either in the chat room or just turn on your microphone and video and tell me how low to go. But we will have to see. I may have to go to L1. We may still end up at the pelvis. This is very frustrating, but this is a fight. I think all of us fight, and we didn't operate on her idly neurologically. She did very well. We got a nice postural correction, but where to stop and how to protect patients' vulnerable bone structures from further collapse is an unresolved issue. Which leads us, since we use cement, to the next patient.
So the next patient, also mid-70s-year-old man, presents with low back pain, bilateral lower extremity pain, and elevated ESR and CRP. Patient had 2 prior laminectomy and discectomy surgeries from L2 to L4. Both were the same levels with a revision. The last surgery was about a month prior to admission. He developed a postoperative wound infection with intermittent drainage from the wound and had been on antibiotics since that time. The patient's physical exam, neurologically intact. His main complaint is pain, wound problems. So here is imaging. On the left is axial and sagittal T2 MRI. You can see a redisc herniation with rostral migration at L3, L4. And then note the midline was taken for the prior laminectomy. And then on the axial, you can see fluid collections above and below the fascia.
So I think, yeah, this is not my case at this time, so he was referred to me. But the patient, I think, several surgeries now you identified, and he had 1 washout. Is that correct?
He didn't have a washout yet. He had a laminectomy, and then like 2 or 3 months later had another laminectomy to make it wider and like try to get it
So now
more.
and so, Colin, if you don't mind telling us what you see on that right-sided image.
So the right side is a T1 post-contrast image with what looks like both discitis, this ventral phlegmon, posterior infected fluid collections, again, above and below the fascia.
So early discitis, prior osteomyelitis, I think there's a CT scan somewhere that shows end plate sclerosis plus perforations, microperforations. So it's discitis, early osteomyelitis, not an immune compromised patient, just larger, cardiovascular disease, very nice guy, in crippling back pain. So let's move forward. I did something that I like to do here for these kind of patients, not braceable, really, because of his body habitus.
So he did the L2 to L4 revision laminectomy, just widened it, L3, L4 discectomy, and resection of that ventral epidural phlegmon, and then placed 2 PMMA spacers with vanc and tobramycin into the disc space, and then L3, L4 posterior fusion. The plan at the time was for a staged definitive fusion 6 weeks to 3 months post-operatively.
And so what was his microbiologic agent? Was it?
Staph epidermidis.
Yeah, that's what I remember. It's staph epi. So staph epi infection. And this is what we did. So we found pus in there. There's an epidural phlegmon. We washed it out. We have a special post-lavage system for the disc spaces. So get a through-and-through washout. And an acutely infected patient with flagrant pus, I like to put in PMMA spacers that have antibiotics added to them. So it's a FDA-approved version. And so we were planning to do surgery, and then tell us what happened.
Yeah, so the patient was clinically doing well. So he was followed with x-rays and then CT scans. This is his most recent follow-up, which is about 3 years post-op. On the left side is a coronal CT. You can see just the PMMA spacer the day of surgery. And then 3 years later, you can see the bone actually grew in the disc space around the PMMA spacer. So 3 years out and still no need to definitively fuse this patient with a cage.
So here's my question to you, Dr. Ryaby. So this man had a documented infection, flagrant pus. We washed him out. We stabilized him at that one critically bad segment. He healed quite well from that. He did so well that I did not see a compelling reason to convert him to a quote fusion. He under guarantee never had a fusion attempt. I'm sitting here as the surgeon. There's a sagittal image also, but he basically healed his L3-4 level without any attempt at a fusion. How can that be? I washed everything out, 9 liters or so with the thoracoscopy irrigator system, through and through, wash out left and right. The PMA spacer was not even, the left one was not that well placed, the right one was well placed, but this is healed through and through. What happened?
Well, I think the infection.
Talking to the microphone.
Oh, sorry. I think the infection, provided the microenvironment for rapid bone growth. Once you got the infection under control, you could imagine those end plates were perforated like crazy from the infection. And now you basically put these PMMA discs, so sort of to keep the disc space reasonable. I don't really know, I'm looking on the left, but you still had that. So that was de novo bone formation because there was nothing else there. I mean, obviously, once those end plates are perforated, you have a good source of MSCs, if you all believe in MSCs or MPCs, whatever you want to call them. He really bridged that space. I'm wondering why L4-5, why 3 years later, that end plate, is it just a bad angle of the CT? Or is that end plate really changed geometry dramatically, and why?
I think all the lumbar disc levels are now starting to degenerate.
Okay.
He tried to talk me into doing a long fusion. I said, no, he has diabetes. He went through a lot of, and so this is the interesting thing for me also. He clearly has microangiopathy. He has a badly regulated A1C level. This is like 8 something. He had a foot amputation from diabetes. So this patient is a vascular path. But I just thought it was fascinating. Thank you, Colin, for showing that and picking up on that in clinic. He healed this despite being a poor host. No attempt at bone fusion. And again, for me, the power of inflammation is very well exemplified there. I think an infection is an incredible stimulus for potential healing due to the factors that you mentioned on a cellular basis. Let me ask you about a certain agent, not representing you in a corporate fashion here, Infuse/BMP. BMP2, is that just a macro-inflammatory agent? Is that the real thing, or are the proteins the thing that induces the bone healing?
Well, I really think of BMP as like the ultimate bone induction agent. There's definitely some data that it's pro-inflammatory, but it's sort of pro-inflammatory in the very narrow constraints where you apply it. And I don't think it really stays there that long. So if you use Medtronic's collagen sponge, I think the BMP stays in the spine fusion site for probably 30 minutes. And then it starts diffusing. And I think that's why a lot of people will add like a calcium phosphate granules and add BMP to that. And there's a lot of interesting calcium phosphate-based bone grafts that you could mix infuse with. And that's what I'm hearing, is that's what most people do.
Well, thank Dr. Gold. And next we come to another, sorry, these are all curveball cases, but I thought these would be very pertinent to tap into your knowledge base. We're having the benefit of speaking with, or hearing from Dr. Mark Kramer, originally a neurosurgical colleague from the University of Wisconsin. Great to have you here. And he encountered a patient with another form of bone healing gone awry this time.
That's right. So this is a case of a 7-year-old lady. She actually had a history of a spinal cord injury from an accident. I don't recall the details, about 50 years ago. So she's now in her 70s. And this is a complete injury up in the kind of mid-thoracic region. Unfortunately, she was essentially found almost comatose in her home after a wellness check. She wasn't showing up to activities around town. Of course, due to the spinal cord injury, neurogenic bowel bladder, had some recurrent UTIs. And she did indeed have some kind of procedure done around the time of the injury. It was non-instrumented thoracolumbar fusion. And as I already noted, despite her injury, she was actually quite functional and lived with multiple cats at home. You can see her metrics here. Unfortunately, due to her, she was severely septic when she arrived. She was only ANO 1 to 2. She also had interestingly, some ptosis, which is still workup is ongoing. And she had pretty good strength in her arms. As best we could tell, of course, she was plegic from the waist down. So here's her imaging. And I'll just scroll through the CT to start here. So you can see from this, that's pretty obviously transected spinal column at the thoracolumbar junction. L1 is essentially gone. There's a remnant of T12 there as well at the top. And there's a kind of a CT reconstruction showing there's a lot of heterotopic bone formation at that level of the transected spinal column there. This axial MRI scan at the base here, this is a T2 axial scan, shows some paraspinous fluid collections, notably kind of in the back here, suggesting superinfection of this area. There's also some new disc gas and fluid collections around the level of the transected spinal column.
So this is a Charcot arthropathy, a neuropathic spinal arthropathy. I've always been fascinated by this because for me, this exemplifies the complexities of bone physiology as a amalgamation. Again, this is paraphrasing the disc degeneration paradigm I talked about before, of patient underlying health, nutritional health, systemic diseases, number one. Number two, mechanics. And number three, bone signaling. And the bone signaling here is way off. The radiographic hallmarks are unregulated, crazy hyperostosis, and then lysis in direct juxtaposition. Can you kind of unravel these things? Can you run through that CT a little more on the left? I thought it's so evocative. How does what go wrong here in a Charcot arthropathy? How can a patient form so much bone and not get it, quote, together?
That I don't have an answer for, but you know, when you have an injury like that, the neurotrophic factors that are being secreted at the site of the spinal cord injury are very osteostimulatory. I don't know if, I know you know this, Dr. Chapman, but remember there were classic papers in the 50s showing that people with head injuries that also had fractures, they would heal their fractures rapidly with exuberant fracture callus. And then David Goldsman in Montreal at McGill, he followed up on this, tried to develop animal models and identify what the neurotrophic factors were. He thought one was nerve growth factor, which is not surprising, but you know, the real question is why, you know, there's obviously been a big vascular event there too. So not only the spinal cord, probably an interruption of vasculature. It's always amazing that distally the bones still look pretty good. But of course there's vascular coming from other places, but I don't really have an answer. You know, remember there's no mechanics, right? Below where the spinal cord injury is and the loss of L1, there's no loading of that lower segment of vertebrae. And I don't know if that's why it's like a non-union.
This is a
That,
non-union.
yeah,
This is a hypertrophic non-union of the first order. Again, if you look at that CT reconstruction, that 3D reconstruction, this body wants to heal this. It's macro-inflamed. So Dr. Gold showed very evocatively a focal inflammation caused by staph epidermidis that exuberantly healed without a single iatrogenic effort at bone healing. We want to have disease control. Here, this patient wants to heal, but this is, completely not going to heal. Infectious disease doctors, right? Tell us about what they did not want us to get close to the patient. They wanted to tap and irrigate and put antibiotics in. What was your experience with this patient care?
So I think, and I'll just kind of briefly mention some of the additional work up here as well. She came in very, very ill, of course, nearly to the point that she needed to be intubated. We already had blood cultures with multiple species, which I note here, she did live with cats and she had Pasteurella show up in her blood. She had quite high-grade sacral decubitus ulcers as well, nearly down to the bone. I note some of her severe sepsis parameters here. And of course, she was hemodynamically very unstable initially, had a pretty heroic fluid resuscitation. And despite that, she was still on pressors actually in the ICU. So there was a lot of hesitation over kind of what to do when she came in. And frankly, for myself as well. And then, as she was being worked up, we got some additional imaging, of course, to make sure that there weren't any other infections elsewhere, including the cervical spine or the head.
If you look at the CT, I just want to again point out, so first of all, unbelievable bone healing efforts by the patient in a severely inflamed internal state, complex bacterial populations from sacral decubitus. I want to recognize Dr. Gottlieb, plastic surgeon. He works with us on these patients with these very complex and challenging problems. Most likely inoculation from cat feces into her system. And this is my thing that I'm leading at. She's obviously chronically constipated. It is very sad for me to see these chronic spinal cord injuries. They should see a spinal cord injury rehabilitation specialist probably once a year just to do a health check. You could almost do it algorithmically or through a Facebook group. Check for UTIs, check for bowel program, check for skin integrity, check for mobilization protocols, check for activity profiles, nutrition, et cetera. These are not hard things. This can be done algorithmically, but it doesn't happen. And she was a member of society. She actually worked despite advanced age and just didn't show up to work anymore suddenly. And it's a tragic story when you see this, but this is, I think, in a systems perspective, a healthcare miss.
I think the other thing to note too is we were starting to work her up, and they came to us initially to kind of wash things out, as you said. And we looked at some of her older imaging, and indeed, about 10 years prior, she did have imaging. She had a very similar appearance to her spine, actually. As you had mentioned, this is kind of a classic Charcot spinal arthropathy with loss of sensory feedback, the repetitive trauma, obviously associated with the instability, and then the vascular and inflammatory changes that like the result from that.
So let's just go ahead with what we did. So
long story short, very sick lady. We were able to get her stabilized. We felt that she had an obvious Charcot arthropathy, secondary to her instability down here and her lack of innervation below her transected cord. We felt she would not survive this unless we did a fairly heroic operation. In this case, we fused her from T8 all the way down to the pelvis, a quad rod construct. We actually washed out that entire kind of overgrown bony mass, and we're able to put a quite large cage at that level as well. We ended up putting some antibiotic beads back there as well. We already talked about that in the last case. And we actually had a combination of a S2AI and also a modified iliac screw to kind of tie in our quad rod construct. She was transfused multiple units during the operation. She was quite unstable. At certain points in the operation, we were able to get her through the operation, get her back to the ICU, and now she's actually transitioned to the floor and actually doing relatively well.
Can you go through the sagittal? So we put a lot of metal in there, which our infectious disease doctors absolutely hate, but I think we have the literature on our side, at least in our world, but the infectious disease doctors don't like to look at our literature. And we put BMP in here. We used mechanical stability. We used aggressive debridement strategies. Again, these cement spacers are added with vancomycin and tobramycin to heat-stable powder form antibiotics in very high doses that give us a local kill. I'm absolutely not sure how it works against Pastorella, but so far so good. We've actually published on this years ago with Dr. Brad Jacobs from our Harborview experience, and the experience was universally favorable. So thoughts about how can we optimize this? We've resected it, we've cleaned this out, we've stabilized it, we've put osteostimulants in there, we've put mechanical stability in there. What else can we do? Should this patient get electrical stimulation, or is this enough?
I would definitely use a spinal stim on this patient.
Why? She wants to heal, so we've given her stability. Tell me why I should add more to this.
Well, the BMP is only going to be around for, if you believe the animal studies, maybe 28 days is how long you're getting any stimulus from BMP. And I think she needs more stimulus over a longer period of time. And the good news about the device that Dr. Chapman showed is that it really does have a big treatment area. So it's not limited to a 1 or 2 level fusion. The electromagnetic exposure goes way up into the thoracic spine, especially, I think you said she's 5'3". So sure, with someone shorter stature, you're going to get really good electromagnetic exposure. So I would, because you want her to solidly fuse. And it's just another tool that will definitely help.
So yeah, so take that under advisement, as they say, but yeah, so far so good. We'll have another case to kind of put your theory to the test. I'm mainly worried about her L4, L5, and mainly L5 is one junction now. So would you get coverage down at that if you have your stimulator pack? Would
Yes.
that cover the lumbopelvic junction? Good. That's my main worry. I sound arrogant here, and if we get her decubita under control, I'm actually very optimistic for her now. She's made a great recovery. So thank you, Mark. Final case before we have Dr. Ryaby's lecture, and that is by Dr. Cameron Hogshead, and he's an orthopedic colleague from the DFW area. Sad Cowboys fan, went to hiding on Super Bowl Sunday about the division rivals' triumphant celebrations. But it's nice to see you back again. He's finally come out of hiding. And he's going to present another case, and these are all cases just for our audience that took place within the last couple of weeks. So this is not just some cherry picking.
Thank you, Dr. Chapman. Also a sad Dallas Mavericks fan now as well, since the Luka Doncic trade. So we have a 75-year-old male. He presents with worsening neck pain, numbness and tingling to his bilateral hands. This was progressive over the last 3 months. He had complaints of dropping items, loss of dexterity and fine motor movements in his hands, and also gait balance and instability. He has a past medical history, interstitial lung disease, aortic valve replacement, coronary arteries, AFib on Coumadin, sleep apnea, and you can see the rest there. Significant past surgical history, very pertinent to his story, was that he had a C1, C2 posterior instrumented fusion for a type 2 odontoid fracture 1 year prior to arrival. This was done by an outside hospital and was later complicated by an MRSA infection, a deep infection, that actually required IND hardware removal 1 month later with long-term PICC line IV antibiotics. You can see there in his sagittal imaging, just a scout that we'll go over later, see bony erosion of a previous odontoid fracture. He was told by the outside surgeon that he'd probably have a plan for later occipital cervical fusion if he develops instability or neurosymptoms, but he was braced in a hard C-collar and didn't really receive follow-up. So you can see his motor exam there. He's got some pretty significant deficits in upper and lower extremities, as well as sensory losses. He's basically a Neurec 4 at this point, classification for myelopathy as well as an MJOA with severe myelopathy. His vital signs were stable upon presentation, and his inflammatory markers, if you're suspecting infection, which we were actually unremarkable. And this is a MRI T2 sagittal and axial scan that he came in and presented with. So here you can see odontoid fractures, persistent non-union, atrophic non-union, possibly infected, hard to say, but there's pseudoarthrosis there. Then you can see some pretty severe spinal stenosis and kyphosis down below to the C6 level. You can see some posterior tissue scar, or scar tissue or possible indolent infection back there, really hard to say. And we obtained a full neural axis MRI imaging, which was, the rest was negative for any infection or spondylodiscitis.
Do you have that coronal CT reformat again?
Coming up.
That sniffing by Dr. Hogshead is not infectious disease.
Apologize.
This is still post-Eagles trauma.
Yeah, that's where it's on. So you can see a CT reconstruction here of coronal, sagittal, as well as axial cuts, and you can really appreciate the C1, C2 instability and translation, the bony erosion of the joints, particularly worse on the C2, the left side. So you can see complete destruction of left C2, lateral mass facets, even some of the lateral mass of C1, and then he's kind of developed a torticollis due to that coronal tilt and collapse down to the left of his head.
So a lateral subluxation. Dr. Ryaby, would you say that the old orthopedic classification is still relevant nowadays to differentiate hypertrophic? We just saw a case example in the Charcot patient from oligotrophic, from atrophic non-unions. Does that differentiation still make sense? And is it a helpful differentiation in terms of what we would do?
I think in the fracture world, it makes sense. Here, there's biological activity here, so I don't see this as like atrophic or even oligotrophic. I'm sort of on the borderline between hypertrophic and oligotrophic. But it's not a good odontoid fracture, that's for sure. And I would think you'd want to fix it.
Yeah, and so then this next question, this is a loaded question, it's a board question. What is the correct time frame to identify and prognosticate bone healing, or expect, I should rather say, bone healing to occur? What is in the spine the expected time to healing?
We'll say in this case, with appropriate fixation, you should use a cervical stimulator on this and get this to heal as quickly as you can.
But what is the time frame? Is it 3 months? Is it 6 weeks? Is it a year? What's the time frame?
I would put the stimulator on really as soon after surgery as the patient can tolerate it. Okay. We do occasionally get patients who complain of pain when they get a stimulator and they put it on literally the day after surgery. And when I say occasionally, 1 in 1,000 patients. Don't exactly know why, but I think it's recovering from surgery, anesthesia wearing off, and it could be that they're hypersensitive and they do feel the electromagnetic field a little, and it's uncomfortable for them. Typically, if you wait 2 weeks post-surgery, they have no problems. They start using the device. But personally, I would use it as early as possible.
I want to give you plenty of time to talk, so let's finish up. So what do we do?
Yeah, so just going quick through, a CTA was obtained, angio of the neck, just to further localize and identify the kind of tortuous, anomalous vertebral artery anatomy that was distorted by his deformity. This is kind of a summary here of what was going on. This is what we did. And so he underwent an occiput to T2 fusion with a C1 laminectomy decompression. Entering back in the surgical wound, there's no obvious signs of purulence or infection. Proceeded with a right C1 lateral mass palm screw, as well as a right translaminar screw. The left side was skipped due to basically essentially bony erosive destruction. The translaminar screw on the right was due to that anomalous vertebral artery anatomy. And then a clothespin tibial strut allograft was placed, spanning the occiput down into the spinous process of the subaxial spine, as you can see there. And then allograft spacers were placed in the C1, C2 joints bilaterally there to basically assist with bony effusion in this kind of bony healing compromised person, in addition to the allograft and BMP.
Strut allografts, how far do they grow in? Do they fully remodel, or is it just an end plate on growth? How much does a strut graft actually incorporate into the human host?
Can you say that again?
A strut graft like this, how much growth or remodeling takes place relative to the host? Does that strut graft get fully incorporated? Do we know that?
After maybe 1 to 2 years, because those strut grafts are cortical bone. And so again, there's appositional bone formation on the strut graft, but really to resorb it away and replace it with new osteoid is a slow process.
We actually put strut grafts into the joints also. Did you have that?
Mm-hmm. And there you can see coronally appreciate his correction, and then strut grafts in the joints there on bilaterally, C1, C2.
So to be continued. Thank you to our 4 fellows for a nice and hopefully evocative case demonstration beyond the usual L4-1 fusion for degenerative disc disease. Great pleasure to have you back here, Dr. Ryaby, a PhD colleague, I think from the Icahn School of Mount Si, New York, and he's been one of the first names of bone healing around the world. He's been with several companies. I showed 2 of the devices here. So he's actually one of the main, I think, proponents and discoverers of pulsed electromagnetic field influences on bone healing. And very curious to hear what your thoughts are in terms of electrical stimulation beyond what Dr. Brighton taught us and what is in our knowledge updates all the time. So thank you for coming here. Thank you for educating us about bone healing. And I would be amiss to not thank Orthofix for their commercial support. Thank you.
Thank you. So thank you, Dr. Chapman, for the nice intro. I decided to use this, and hopefully I'll finish in enough time where we can discuss what does real-world evidence really mean. Disclosure, I am actually now a part-time employee of Orthofix, and I do have stock in Orthofix. The agenda today is I wanted to talk a little bit about science, and we do have some interesting new science, and it really has to do with mechanism of action. If any of you looked at review articles on electrical stim or pulsed electromagnetic fields, you'll see that all of the standard things we were doing 30 years ago, stimulating cell proliferation, collagen synthesis, growth factor synthesis and secretion. These are all the things. But really what we hadn't done is figured out how does a cell sense an electromagnetic field. So in the last 12 years, there have been work really by Italian and British groups on pulsed electromagnetic fields and adenosine receptors, but all they've really shown is that they can get more adenosine receptors on the surface of cells. Nothing about does the adenosine receptor really sense the pulsed electromagnetic field signal and therefore activate the cell. So we started a project with Jody Donato's lab at Cleveland Clinic. And basically, it was really asking this question. So the high affinity A2A receptors, the low affinity A3 receptors, and remember, these adenosine receptors are on mesenchymal stem cells, on pre-osteoblast, early osteoblast. So the question really is, can we show whether these receptors are one of the mechanisms or the mechanism for sensing the field? And so what we did is we used this system. Everyone knows CRISPR-Cas9 in terms of being able to go into a cell and either insert a gene exactly where you want it, or you can cut a gene out. And that's basically what we did. And you may know that this discovery led to the Nobel Prize for a woman scientist at Berkeley and her colleague at the University of Paris. And I'm blanking on their name. I should have looked that up at 5 o'clock this morning. But anyway, so what we were able to do is basically generate an MC3T3. So this is a mouse osteoblast line that is very standardly used in research. And we were basically able to create cells that had a knockout of the A2A receptor. So no A2A receptor, no A3 receptor, and then we did a double A2A, A3 knockout. And
Just quick interruption.
Sure.
I had to look up myself. Jennifer Doudna and Emmanuel
Yeah.
Charpentier of UC Berkeley and University of Vienna discovered the CRISPR-Cas9 system.
right, it was Doudna, Jennifer Doudna, yeah. So anyway, so what we did then is we looked at alkaline phosphatase levels and just showed that the wild type cells exposed to the electromagnetic field have a very strong response. Cells in blue, where we had knocked out the A2A receptor, responded the same as the normal cells, but when we did the A3 receptor and the double knockout, we basically reduced the response by, I would say, 60%, maybe 70% in some experiments. And then what we had to do is ask the question that if we put back the gene for the A3 receptor, let those cell lines grow up to maturity, show that they're now making A3 receptor, could we in fact get the response back? And so this just shows we'll stick with alkaline phosphatase for the time being. So basically, electromagnetic exposure, about a 3.5-fold increase of messenger RNA. As you see, if you knock out the A3 receptor, there's really no stimulation of alkaline phosphatase. If you expose that knockout to PEMP, there's a slight increase. But if you knock in the receptor, so we put the gene for the receptor back in these cells, you almost completely restore the response to electromagnetic fields. So this is really the first time anybody's been able to, at the gene or molecular level, really identify a receptor that's required for the pulsed electromagnetic field response. When I left Orthofix due to COVID, this is where we were. And this was basically, so you would argue that if you could overexpress the A3 receptor, could you get from a 3.5-fold stimulation with pulsed electromagnetic fields, could you get it to 7 or 10 or 20? And this is something that I'm hoping that we're going to be able to restart. We're trying to get funding for this now with the group at Cleveland Clinic. But this is pretty exciting because, as Dr. Chapman said, I've been working on electromagnetic fields really since like 1980, and I know some of you weren't born yet. But in the early days, it was really these growth kinds of experiments. Now we have these great molecular biology tools, and we could really get at the molecular level these mechanisms, and I think it's really exciting. So basically, I didn't show you all the data, but this is really the first evidence that adenosine receptors are, quote, required for the PEMF response. The knock-in experiments certainly confirm that the A3 receptor sees that EMF field. And then what we really need to do in all of these experiments is quantify the receptor numbers, because we don't know in a wild type or unmodified cell how many receptors per cell there are. And when we do the knock-in, maybe we're only getting 50% of the normal level of receptors. We really don't know. So the second part of the talk is really follows the title, which is data from 2 recent publications, one on lumbar and one on cervical fusion. So this is a paper published in the International Journal of Spine Surgery. Some people you may recognize. Dom Cork is really one of my favorite people in the world. Dr. Aleem at University of Michigan is very active in many different areas of spine, including epidemiology. So this study, unique for a post-market study because it was a prospective multi-center study at 10 sites. There were 142 subjects that completed the study protocol. If you go to clinicaltrials.gov, I'm still listed as the PI like 6 years later, and it was supposed to be 300 plus patients. But basically, standard inclusion criteria, you had to be multi-level, at least 2 or more level fusions or a prior failed fusion surgery, and diabetes, osteoporosis, current nicotine usage was all measured. In fact, osteoporosis was measured at study entry by DEXA scans, so it's really an assessment of osteoporosis. And then their fusion rate at 12 months on CT and radiographs, and then ODI, EQ5D, et cetera, was all measured. So overall, the study results were 88% fused using the device again. This device requires a minimum 2 hours a day and for a minimum of 6 months. And then if you look at the difference in success rate based on the number of risk factors, this fell down to like 82.3 from 88 overall, but still a very successful technology. And then EQ5D, as you know, this is not the greatest score, but certainly a reasonable decrease in ODI, about a 50% reduction in ODI at 12 months. And I think the important thing here is if you stratify, looking, for example, at BMI, nicotine, there were a reasonable number of smokers, 27 out of whatever that is, 130, 140. But again, not the ends you really want to see if you're going to try to get statistically significant difference. So really no independent factor really stratified, showing a statistically significant effect. But anyway, so to summarize, 88% of subjects had successful lumbar fusion. It was 88.5 for one risk factor, decreasing to 82.3 for 3 or more risk factors, and then significant improvements, statistically significant in ODI, SF36, EQ5D, and VAS pain were observed, just what you would expect in a successful lumbar fusion study. Now, the good news is that Dr. Hassanzadeh, who's at Johns Hopkins now, practicing really in the Bethesda area and Sibley in Washington, he has been able to go and collect about 67 patients, control patients that did not get STIM, that he's been able to propensity score and match them, and that paper is now submitted and awaiting the initial review. So at least that will now have a control group. Now, the second paper is basically led by Veek Patel. Veek's at University of Colorado, Department of Orthopedic Surgery. You can see a lot of the same doctors that were in the lumbar study, and this is because a lot of these doctors I know very well. So this is a cervical fusion study, prospective, at 11 centers. The nice thing about this is there were 160 subjects in the cervical STIM arm. We were also able to get 53 subjects, and I use the term retrospective. They're not really retrospective controls. They're patients who either didn't want to use the cervical STIM device that was prescribed for them, or their insurance wouldn't cover the use of the cervical STIM device. But the good news is we at least have a comparative arm. Again, this is a tough group of cervical fusion patients. You're either multi-level, prior failed fusion surgery, diabetes, osteoporosis, nicotine usage. Again, osteoporosis was based on DEXA scans, standard exclusion criteria, and then again, fusion rate at 12 months on CT and radiographs. And like the lumbar study, I should have put this in, all levels had to be fused to be considered a successful fusion. And just to take a quick look, who are the control group? Well, the control groups are primarily 1, 2, and 3 level, whereas the PEMP group, it was almost 50% 2 level, 28% 3 level, and still around 15% 4 level fusions. So certainly just what I would say Debbie would say if she was talking to you about using these devices, the patients with more risk factors are the people that you really want to use these devices on. If you're relatively healthy and a single level fusion, it's probably not necessary. But you can see here that basically 90% with the STIM fused versus 60.4% in the control group. And we can talk more about this control group. If you look at patient risk factors, now this looks like a very exciting number, but come on. There were only 5 patients in the control group that were osteoporotic based on DEXA scans. So I think it's hard to really be sure about 34 patients in the STIM group versus 5. Yes, it looks statistically significant, but you'd want this number to be at least like 25 or 30. Multi-level disease, there's no doubt that there was a big difference in efficacy based on multi-level disease. You know, a slight one based on age. Nicotine use, I think we all appreciate that. Nicotine use is a negative factor for good fusion outcomes. And sorry, this is patient risk factors. I even confused myself, I apologize. So patient risk factors, and then if you look at outcomes, the only thing that was really statistically significant was multi-level surgery, which that was a big difference, 91 versus say 49% successful fusion. BMI, I don't really think is a good measure. I'd love to hear any of your comments, but I think there's probably, you can be a BMI of 35 and actually be pretty athletic, not necessarily fit, but you could certainly participate in athletics, lift weights, do many things. So I don't know where that cutoff for 30 really is, but it did show up statistically significantly different, 63% in the control group versus 90% in the STIM group. And that's really, and the numbers are reasonable there too, 27 versus 82 patients. So summary, 90% of these cervical stim subjects had successful fusion compared to 60.4% in the control group. And right there, I would say you should be using cervical stim on anybody with a risk factor. And certainly in multi-level fusions, whether the high BMI is really meaningful, I don't know, but certainly multi-level. We've showed this in other studies. We published a paper in like 2018 on 3 and 4 level lumbar fusions. That also was a good paper with a couple of really good investigators. David Okonkwo enrolled about 15 patients in that study. So anyway, we think, this is something Orthofix is committed to doing, is to continue. Now, we're probably not going to run a randomized, double-blind, placebo-controlled trial anymore because these products are now on the market, FDA approved. But certainly any new indications, there might be opportunities to run placebo-controlled, double-blind studies. And, thinking about like vertebral fractures, there's an interest in that. I talked to a guy, Ziv Moses, neurosurgeon at Beth Israel in Boston, and he's really interested in that. And again, I've only been there back 4 weeks. But I'm gonna, hopefully, if I was here actually, Dr. Chapman, I don't know if you know this, but I was here 5 years ago on this date giving a talk. And so maybe in 5 years, there'll be a couple new papers, maybe we'll have a little bit more receptor stuff to talk about, but it would be, obviously, if there's new things to talk about and to show you, or maybe new applications in spine or other areas, it would be nice to be here. Thank you.
Can you stay up there and go back to the slide with the receptors, the A3 and A2 receptors? That's kind of a cool slide. I'm going to join you at the podium. So bone healing is complex. Bone healing has a number of factors. I'm going to first ask you this. So can you hold my microphone? Sure. So when I put this on, I'm hopefully putting it on the right way.
Correct.
Is that the right way?
Yes.
So how do you know that I'm actually wearing this when I, as a clinician, prescribe this not inexpensive technology? How do I have a knowledge and an affirmation that the patient is actually wearing this device?
So we have an app called Stim on Track. And so what all of our representatives around the country do is get the patient to download that app onto their Android or iPhone, and that syncs via Bluetooth with the device, And so as soon as the patient turns the device on, the device is connected to the phone, and then the patient can look at their phone, especially if they're coming back to see you, Dr. Chapman, and it's 3 months since they got the device. Hopefully they're looking at their monthly treatment calendar, and it would show green that they use the device at least 3 hours a day. It would be yellow if they used the device that day, but they didn't quite get the minimum 3 hours of treatment, and then it would be red if they missed the treatment. Debbie might have a couple other features that I'm not.
So I can see a number here. So how many hours in a day would a patient be asked to wear a device like this to get the stim?
The cervical stim is 4 hours a day, right? 4 hours a day.
Continuously or
No,
in
they can break
sequence?
it up. They can
Break it
break,
up.
in
So
fact,
4 hours total.
I recommend most of my patients at least start breaking, don't start initially with 4 hours all at once. Sometimes, depending on the patient, if it's a elderly, frail, small woman, I will say, let's build up to it. I have some clinics that say by their first post-op, let's have them at the 4 hours a day.
Then
And the lumbar is 2 hours a day.
okay, wow.
Post-op.
You get a benefit for lumbar fusions? That's a harder one, I would think.
So, and then the other thing is, there's a physician's portal where your office or your research person, study coordinator, whatever, can also log on and see exactly what the patient sees on their phone. So that if you want to stimulate, like you fellows, you know, you want
is
your
Debbie
patients
Blaskowitz.
to all do great.
I'm being
So
fitted.
you could literally log on, look at 10 people that you've written a script for, and what if they're yellow most of the time? Or they have a lot of red in their monthly calendar? Well, maybe you or a research person could call them up and encourage them to really use the device.
This is actually not uncomfortable. I'm not getting paid for this, and I have no professional relations with Orthofix. This is not that bad. 2 hours a day. So again, why less time in the lumbar spine? I'm not a small person for the cervical spine.
Purely based on clinical trial.
Okay, all right. I'm old enough that we struggled with lumbar fusions in the past, and we put little electrodes and battery packs into patients
Right.
to get them to heal. We had to make arduously clear that we dissected far away from the metal so that there was no contact. It actually seemed to heal bone. This is direct proximity. So
Right.
these cables
DC
had a
stimulation
pretty cool
devices,
thing.
yeah.
So how physically can you tell me you're getting the same bone healing effect through the skin with a post-magnetic field that I'm wearing 2 hours a day compared to a battery pack that's installed?
Well, so, you know, DC is different, like you said, that you can't have the electrodes come in contact with metal, but literally, we've done the calculations with Maciej Zabrowski at Cleveland Clinic, who's a physicist, expert on magnetic fields, and we're getting essentially 10 to 20 millivolts per centimeter of electric field induced in the vertebrae. And I could send you these papers if anybody wants to see them. But we can do this, and we felt that compared to an implantable, which there are other issues with the implantable, and then do you want to go back in to take the implantable out?
No.
So that's why really even our competitors are essentially all non-invasive. High Ridge Medical, which bought the EBI technology, the DC stimulation technology, probably does maybe a couple of million a year at the most, mostly in foot and ankle fusions, is where that device is still used.
I'll ask you the ultimate question, and then I'll ask a practical question about our last patient. So the ultimate question in terms of bone healing. We had, as a resident, Professor Carl Brighton at UT Southwestern in Dallas, where I trained, and we asked him the question, Bert Mooney, our chair, asked him the famous question, how much does electrophysiology contribute to bone healing? He's kind of the godfather, I would think, of bone healing in terms of electrical stimulation. I think you'd agree with that. And he said 10%. Now, 3 decades later plus, is he still right? Does
No,
bone
I
healing-
would say-
What's the percentage contribution?
25 to 30%.
Okay, that's not bad. And this is my final closure question, unless somebody has a question. We showed this horrible neck condition that we did a pretty wild surgery on. I think we did a nice carpentry job and a nice biologic job. Patient's doing very well now. He's neurologically improved. He's home. He's not in a collar. What would we have to do to get this Medicare patient to get approved for the primary neck collar so we can optimize his healing? He certainly has all the risk factors, so I'm now double stimulated. I feel totally radiant.
Might get taller.
So what would we have to do to get him approved for this thing, to get this to heal? He had a non-union, he had infections, he had 4 surgeries in outside hospital. He has a lot of systemic diseases. He has now a 5-level, 6-level fusion attempt, 7-level, who's counting? So what do we do as clinicians to get this approved?
It's actually very simple. Medicare guidelines first are multi-level fusions, cervical, lumbar, probably even thoracic, are covered post-op. You can order it prior to. All it takes is a prescription, patient demographics, last chart note, and at least a date, and I get the op report later. That's it.
Great.
Send it to me, call me, and I
of
come in and pick
information.
it up, and I do the insurance coverage.
Do I have a chance to serve as a photo model for OrthoFix?
You would be a
I wear
perfect
them well,
one, yeah.
right? I wear them well.
I had a quick question.
Fire.
In the same vein as that prior patient, if you were to do either a thoracic fusion, which one would you wear? And how high have we studied, is C1 to occiput type fusions covered in the range of these wearables?
I would say, so remember, there is magnetic field above the coil, so here.
You show me.
Over here.
Use me.
So there's magnetic field that comes here, and in fact, when we did an odontoid, and there's magnetic field that comes here. So really, I would say, in a lot of patients, you're getting good electromagnetic field exposure for 6 levels. But if you're talking about like Shaq, it's probably less, right? Or somebody who's 6'7" compared to somebody who's 5'1", the 5'1" person is just gonna have more levels potentially covered. And this is something that we're gonna be working on. Adult deformity, that may require a whole new device design, like using Dr. Chapman as an example, it may require this anterior coil, this posterior coil to be much larger, and it might be something where we have to have multiple sizes depending on what is the length of the construct, et cetera. But, what drove this is the fact that there are surgeons who use this device for their adult deformity corrections. And they really believe that there is a clinical benefit. There hasn't been a trial yet. We're hoping to do a retrospective study. You would see it at like the NAS meeting or ISAS meeting, not the next one coming up, but hopefully the year after.
Why would I not, in a high-risk patient, do this before surgery? Get all those A3 receptors activated? Would I? Would I not? Wouldn't that make sense to amp a patient up, so to say? Ha, ha, ha.
Well, I think it's a payer issue. We don't have data on that, so.
But philosophically, it would make sense, right?
Potentially, because, think about knee replacements now. Many doctors use the neuromuscular electrical stimulator for 4 weeks prior to doing a knee replacement because they've proven in clinical studies that the patients who got ultra-strong quads actually recover from their knee replacement surgery quicker than those that don't. So I think we'd have to prove that clinically.
So I'm ready for a fusion now.
Yep.
Always a pleasure, thank
Always
you.
good to
Dr.
see you.
Chapman,
one
one
more
quick thing,
thing.
if you look at the lumbar in the back on the treatment area, if it's 2 hours a day, but if you have, someone that's, the whole spine has been fused, I have them wear 2 hours low and then 2 hours high. Yeah, and I always go I go lower first because I think that's where most of our focus is. But if a patient's willing, I say, okay, wear it up higher. I don't get a lot of those patients, but when I do, that's what would be my recommendation to them.
I'm going to avoid the corny statement of this was a very stimulating topic, but thank you for educating us.